called Live Better with Pulmonary Fibrosis. And we'll do that through having speakers, as Dr. Kershaw, and have other topics we're discussing. And I'll let Shelley Mathis talk a little bit about the planning that her steering committee has done as far as meetings for the rest of the year. I can say this to you because there are patients or caregivers. If I have a tendency to cough a little bit or run out of breath, we're all on the same deal, as you understand. Let me first introduce, if I may, Dr. Corey Kershaw. Dr. Kershaw, by definition, is the Associate Professor at UT Southwestern Medical Center, Department of Internal Medicine. He is a pulmonologist who works with patients. He specializes in interstitial lung diseases. In addition, he also serves as the medical director of the Medical Intensive Care Unit and Respiratory Therapy at the William P. Clements University Hospital, where we're located today. And he also was involved, which I would hope he addresses and talks about, some of the projects that test and trials for pulmonary fibrosis patients and interstitial lung disease. And he's kind of the guy for those things and somebody that we want to get to know better. So with that, I'd like to have you help me welcome Dr. Corey Kershaw.
Let's see, is that good volume? There, okay. So I'm going to turn that off so there's not a lot of feedback. Okay. So when I was asked to give a lecture talk, I don't say lecture, I'm talking at you, which I don't want to do, with ILD 101, I sort of, this is something new. I've not done this in a formal fashion like this, but I did realize that this is probably something that I do in my clinic when I meet many of you, many of my own patients are here today, and introduce them to this concept of interstitial lung diseases. So the way I'm approaching this today is, what are the questions that I hear all the time? And so I sat down and thought about probably many of the conversations I've had with you here today. What do you want to know? And these are just some of the things that I thought of. You know, what is the difference between interstitial lung disease, pulmonary fibrosis, I'm using air quotes there, and IPF? Those terms are tossed around rather loosely, and I hope by the end of this, you'll have an understanding of what those terms mean, and they don't really mean the same thing. What does an interstitial lung disease mean? So to answer that, we're going to get just a little sciencey. We're going to go to medical school for just a little bit and talk about lung anatomy and what that means in interstitial lung disease. Why am I short of breath? I hear that all the time. I understand that more than anything else, that's the big concern. I don't understand why this disease makes me short of breath. And more importantly, why am I not getting oxygen? I'm short of breath. I shouldn't be on oxygen. Why is the doctor not prescribing that for me? How are we going to figure out what this is? How will my diagnosis be made? Do I need a lung biopsy? And why are you having such a hard time telling me what this is? That should be a straightforward question and answer, right? I hope at the end of this you'll at least have some understanding that it's actually really hard. You're telling me I have ILD. I hear about these new medications around for IPF. Are those the right thing for me? And are there any other treatments for ILD besides the medicines that I hear about all the time? These are just some of the things that I'm going to talk about, and we have a question and answer at the end. So if I've missed anything that you need to know to improve your knowledge of this disease, I'm more than happy to at least make an effort to answer those questions. So I like to use the analogy of an umbrella when I'm speaking about this, the umbrella of interstitial lung diseases, because it refers to a broad category of lung diseases. So it's the overlying name for this family of diseases. And there are many of them. There's, and I'll just read them to you. There's hypersensitivity pneumonitis. There's IPF. There's NSIP, LAM, which is a very long name, lymphangiomyomatosis. PFE is all the letters here because these words of the heart, chloroparenchymal fibroelastosis, connective tissue disease associated interstitial lung disease, cryptogenic organizing pneumonia, drug or medication associated ILD, and then PLCH, which is pulmonary cell histiocytosis. We use these letters because we made this very difficult, right? We come up with these really hard names to call these things, so we use a lot of acronyms and letters. These all fall under the umbrella of interstitial lung diseases. So IPF and ILD are not exactly the same thing. IPF is a type of interstitial lung disease, but not all interstitial lung disease is IPF. And that's why I think a lot of us here may have IPF. We may not have IPF, but it's all under the umbrella of interstitial lung disease. I'll come back to this a few times. So what is this? What is an interstitial lung disease? In order to answer that, we have to define what the interstitium is. This is where we're going to go next. We'll hear for a little bit. This is a cartoon of what your lungs look like. You'll notice, now this pointer works. It's actually not appearing up there. I don't have a way to go. So what you see in the middle there is the windpipe. The white little tube there at the top, that's the trachea for the windpipe. And as that enters into your chest, it branches about here, sort of about like the middle of the breastbone is where that branch point is. And one branch takes air to the right lung, one branch takes air to the left lung. And as they enter into the lungs, they begin to branch more and more and more, smaller and smaller and smaller. The terminology changes then. We don't call it the trachea. After the branch, we call it a right and left bronchus. As they branch more and more and more, we talk about secondary bronchus, tertiary bronchus. This means that it's more and more divisions. Eventually, as they get smaller, the language changes again. We refer to the smaller airways as bronchioles. These are still conducting segments. So we're not even, at this point, the air is still on the road, still traveling to the operational part of the lung. When it gets to the very end of the airway, we get a branch that looks like that, sort of like a bunch of grapes, right? And we refer to those as alveoli. Alveoli are the functional parts of the lungs. Everything else that I described to you now, they're all just like roads to get down to the alveoli, to take the air down into the very, very end part of the lung. And there's about 2 million of these. So we branched out much all the way to become to a very, very small microscopic part of the lung called the alveoli, which is really where the working parts are. You can have disease anywhere along this way, however. You've heard of bronchitis, right? Bronchitis is an airways problem. It's inflammation of the airways. Other diseases like asthma, those are airways problems, spasming and inflammation of the airways. The diseases of the interstitium affect these microscopic areas, the alveolar parts of the lungs. And this is what that looks like under a microscope. If we were to do a lung biopsy of someone with a normal lung, this is actually what it looks like, the alveolar areas of the lungs. And if you notice, it's mostly air. So all the white stuff you see there, that's blank. That's air space, we call that. And I'll show you again. And so you can see that the functional parts of the lungs are these little thin lines. And we can actually take a much closer look at that. This is what it looks like up close. And the little space in the middle there is what we actually refer to as the alveolus, or the air space. If you get an infection and that air space fills up with infection, bacteria, mucus, we call that pneumonia. Pneumonia is a lower respiratory tract infection. An upper respiratory tract infection that affects the airways, that's what bronchitis is. It's kind of a spectrum. Sometimes it's hard to tell the difference between bronchitis and pneumonia. That's another common question. The doctor said I had pneumonia, but they acted like they didn't know. It's kind of hard, actually. An X-ray can be helpful for that, but sometimes the X-ray doesn't show that there's something on there that looks like pneumonia. Sometimes it is a guess, and that's frustrating, I realize, but again, this is hard. So you'll notice, again, this kind of looks like a spiral. I may have used that analogy with you before too. You know, the lungs, the big parts of the lungs here kind of look like a big spider web, right? And the spider web is mostly air with little thin lines surrounding mostly the air. This is the operational part of the lung. So I've made a cartoon here to maybe try to demonstrate what happens at that little line part. So at the top there, you'll see this is the space for the air, the alveolus. So this is where the oxygen starts. And then we have two other little segments here that we have to traverse. One of those segments is the interstitium. Okay? And then the next segment below that is a blood vessel. So those are the three parts, the three compartments, if you will, at that microscopic part of the lung. Airspace, interstitium, blood vessel. So the interstitium is sort of like the part that the oxygen molecule has to go across to get to the blood vessel. And again, there's about 2 million of these. So many, many parts. This is just sort of compartmentalizing into one part. So in order for oxygen to get into the bloodstream, it has to go across the interstitium. And there's a lot of things in the interstitium. There's cells, there's sort of some connective tissue holding everything together, sort of the lattice work of the lung holding everything together until you get into the blood vessel. We call it a capillary at this point. The blood vessel will work too. And this is what normally happens. Now, in an interstitial lung disease, that little small space that separates the alveolus from the blood vessel, there's something wrong there. And to make this simple, we'll say it's thicker than it should be. Okay? So now, as you can see, if those oxygen molecules have to get across into the blood vessel, they have further to go. And in fact, not only could it be further to go, but there could be other things in the way. So not so much just thickness, but more cells in the way, more garbage in the way, more of that connective tissue stuff that builds up and builds up and builds up, that not only makes the interstitium thicker than it should be, but harder to get through. And the whole point of this, the reason why the lungs are there, is to move oxygen into the blood vessel and to move carbon dioxide out. That's what we're showing at the top of the page here. So instead of having this, where everything is nice and thin, we see something like this under the microscope, where everything is now thicker than it should be. And a nice analogy that I'll use sometimes, it's like if you're trying to cross the street. It's pretty easy to get across a narrow path like that. It's nice and quiet, there's nothing in the way, it's easy for oxygen to get from one side of the road to the other. But in an interstitial lung disease, it gets a lot more complicated. You've got much, much further to go. There's a lot of stuff in the way that's going to make it harder for you to get there. There's a lot of mechanisms for how this happens, but in a nutshell, that's what's happened in an interstitial lung disease, is that little narrow space that's used there kind of as a placeholder to hold everything together, give the lung structure, and allow the oxygen to go across into the blood vessel. It's now causing trouble. It's bigger than it should be and hard to get through. So how does it affect us? Well, shortness of breath in many ways comes because of this thickened interstitium. Shortness of breath is actually a much more complex problem than that. There's actually some neurological components to it. But again, just to sort of make this a little simple for all of us, the big reason that we may have this now is because of that thickened interstitium. The lungs are now stiff. And because of that stiffness, they're stiff and they're sort of shrinking a little bit, because now you'll notice on that slide that I took where you have those big wide open air spaces before, now they're getting a little narrower and more plugged up. So everything sort of shrinks down. The volume of the lung gets smaller. That's why we're always checking your volumes of those going lung function tests. We're going to get an idea of how much smaller the lungs may be getting over time. Because of this stiffness and smaller volume, taking a fuller breath when you want to walk around your home, even exercise, is much harder to do. One of the first things we do in response to exercise is actually take deeper breaths. It's something very subtle, you may not notice it, but that's really how the body get you more air. It's not breathing faster, it's actually breathing deeper first. Breathing faster comes later, but if you can't take a deeper breath, you're going to feel that, and your body is going to react to that and give you a sensation of being short of breath. That's a complicated problem. And that can be improved with conditioning, like in a pulmonary rehab program, which can also be very helpful with tolerance of the shortness of breath. Just, as I mentioned, this is a neurological problem, so you have to sort of reteach your body to acclimate to that shortness of breath better and make you more tolerant of it. That's one of the big advantages of pulmonary rehab. That's why we talk about pulmonary rehab so much, because a lot of the things that we do, medically speaking, from a medicine standpoint, may not get at some of these symptoms. Pulmonary rehab can help with those symptoms. So what about low oxygen? Well, low oxygen levels can cause fatigue, poor energy, that just worn out feeling that some of you experience, but not necessarily shortness of breath. I say not necessarily because certainly if your oxygen level is very low, your body's going to have air hunger and want more oxygen, and maybe react by having you take deeper breaths and more breaths. And if you're stiff and thicker in your interstitium, that's going to be hard to do. But the first experience you may have symptom-wise could be fatigue and poor energy. That's when oxygen is needed. But oxygen, just for shortness of breath alone, may not help. And in fact, you have to objectively prove that your oxygen levels are low before you can just prescribe it. And that's done with an office test. You can either do it in the office or at home, but usually most of you probably experienced having that tested in the office. We check your oxygen, that little meter we put on your finger, and the level has to be 88% or less. That's a Medicare rule. That's based on evidence. You know that once the oxygen levels are below that, bad things start to happen with the heart, the lungs, the kidney, the brain, all sorts of things. That's sort of a threshold number where physiology changes. We start to see damage at a microscopic level in organs, so that's why that number is 80%. It's not really arbitrary. It's a true scientifically proven number, but it really comes back to what Medicare will cover. So you have to prove that you have that number. And we should be retesting that a couple of times a year if we need to, not annually. So 88% or less is the magic number. So shortness of breath and low oxygen levels do not necessarily go together, and they're named differently. So the next big group of questions, what do I have? What type of ILD do I have? Is IPF the same thing as ILD? We alluded to that a little bit already. And what about this term pulmonary fibrosis? Is that the same thing as IPF? And how are these different types of ILD different, and how are they the same? So I'll refer back to my umbrella again, and to answer the IPF-ILD question, as I said before, ILD and IPF aren't the same thing. IPF is a type of ILD, or interstitial lung disease. So all IPF is a type of interstitial lung disease, but not all interstitial lung diseases are IPF. When I hear the term pulmonary fibrosis, I start to get a little uncomfortable because that doesn't really mean anything. The pulmonary fibrosis could refer to idiopathic pulmonary fibrosis. It could refer to an ILD that we don't have a good description of otherwise, or an ILD that we really haven't made a diagnosis of. For me, I feel like when I hear the term pulmonary fibrosis, that's usually somebody who's referring to the family of ILD rather than one specific diagnosis. Now, we may say pulmonary fibrosis when we mean IPF, because it's easier to say pulmonary fibrosis rather than idiopathic pulmonary fibrosis. But I'm basing this statement on many of you that have come to us in the clinic with, like a second opinion. And you're saying, the doctor told me I have pulmonary fibrosis. And we start looking at your data, and it looks nothing like IPF. It looks like something under the umbrella, but not IPF. And then we start having that difficult conversation of, why did my doctor tell me I have pulmonary fibrosis if you're telling me that's not what I have? And I'm like, well, that's not what I'm saying. I'm just saying we have to redefine our terms a little bit better. So for me, Tion's smiling in the back, so she hears us say this all the time. We really, at UT Southwestern anyway, in our ILD clinic, we try to avoid that term pulmonary fibrosis because it's a little clunky and really, really non-specific. It can lead you down a pathway of thinking about IPF, when in fact it's not IPF at all. That's how I interpret that, and I know my partners here, we view that the same way. So that's why that term actually has a lot of meaning. So we're very careful about using the terms ILD in the IPF when we mean IPF, not when we're referring to the family of interstitial lung diseases. And you guys probably know many physicians, including lots of pulmonologists, aren't comfortable with these distinctions. That making this diagnosis is hard. We'll go through that in the next few slides. But they tend to refer to all ILDs as pulmonary fibrosis because they may not think about the large group of things that live under the umbrella. So that's why they kind of lump it all together. For you, that's a bit difficult. And that's why at our medical center here in our clinic, we do everything we can to educate you so you kind of get rid of the things that we're told to that were incorrect and try to build back up again the things that are correct. So why do we make this distinction? Well, it's because there are so many different things that can cause your interstitial lung disease. Rheumatoid arthritis, that's a picture of someone's hand who has horrendous RA. That can be a cause of interstitial lung disease. We're always interested in your home environment, right? We're always asking about, floods, and hot water heaters, et cetera, because if you have one of these things burst or have some damage in your home and don't clean it properly, you can have a mold buildup like this. Those molds inhaling those molecules that can lead to an interstitial lung disease. Molding hay, there's something called farmer's lung. You don't see that here. I find that usually they have outbreaks of farmer's lung, that tends to be like in the Midwest and things like that. But exposure to that can cause an interstitial lung disease. Again, so the mold that lives in the hay, if you don't store it properly, gets wet, mold grows, can lead to an interstitial lung disease. We're always asking about pets. Dogs and cats are fine. I love birds. Birds in the house, not a good idea. And it has to do with these little proteins that live in birds' feathers. The birds themselves aren't the problem, it's what's in the feathers that's the problem. So when birds preen, all these little proteins aerosolize. You clean the cage or even are around the cage, even if it's in the home, anywhere, you inhale those over time, that can lead to interstitial lung disease. We're always interested in all your medications, both past and present, because there's a gigantic list of medications that are known to lead to interstitial lung disease over time. Not everyone who takes these medicines gets ILD, and some are more common than others. In my interviews, I'm always asking about amiodarone. That's because it's one of the more common ones. It's common as a cause of ILD, but it's a common prescription. A lot of cardiologists use it as a medicine for atrial fibrillation to control the heart rhythm. There's some antibiotics that do it, lots of chemotherapy drugs that do it. So we ask about if anyone's had a history of cancer before, because you may have had a chemotherapy drug 5 years ago that started an ILD process that started to take off after the drug was stopped. That's why we ask those questions, because we're doing everything we can to make a correct diagnosis, which really is the hardest thing to do. And it all revolves around that long interview you have with us in the clinic. And that may be one of the reasons why sometimes the diagnosis can be elusive at first, because you may not have had that time with a physician to really dig through everything. I hear that a lot with my own patients after we finish the conversation. No one's asked me these questions before. That's a bit of an injustice, because you get labeled with something that may or may not be true because we didn't really dig down and ask all these questions. And I find sometimes by just asking the questions, you can trigger some memories that you hadn't thought about for a while. So sometimes something comes up on the second interview or the third, like, hey, you asked me those questions and I haven't thought about it. We did have this water damage before. I had forgotten about it, or I did take this medicine years ago and I just hadn't thought about it because no one asked me about it before. That's why we do that, because we have to tease out all the different causes of interstitial lung disease before we can really hone in on a diagnosis. After that interview, the objective data that help us are the high-resolution CT scan, CAT scan, maybe a surgical lung biopsy. I say maybe because we don't always have to do that, and I'll talk about why that is in a second. After we talk about it now, how are you going to make my diagnosis, doctor? Do I need a lung biopsy? Or after the fact, why did I need a lung biopsy? No one's, you're not sure what this is. Why are we going to do a lung biopsy to answer the question? And why are you pinching everything on this CAT scan? If you want to know what I have, why don't you just take a pizza and look at it under the microscope? Why does the CT scan matter so much? Let's dig into that a little bit. As I mentioned, you saw before, there's all these long names and things like that. So how in the world did we end up with these long names? So let's blame pathologists for that. These are named by pathologists years and years ago. And because certainly 20 or 30 years ago, everyone got a lung biopsy. That was just the way it was. You went to see a doctor, they asked you some questions, sent you off the operating room to get a lung biopsy. And so pathologists were getting all these slides and having trouble speaking to each other about what they saw. The language was messed up from medical center to medical center. So some really smart people got together and decided we need to codify this. We all are seeing the same things. A lot of them look the same. So let's group everything together and describe maybe all the most common patterns we see. This really is pattern recognition, is how the pathologists work. It's a lot different than, let's say, cancer. Cancer can be hard too for a pathologist, but most pathologists, certainly even relatively inexperienced pathologists, can look at a slide and say, "Yep, that's cancer." They may have more trouble telling you exactly what kind of cancer it is, but they're going to be able to answer that question pretty quickly. With ILD, it's much, much harder because the pattern has to be there for the pathologist to give it a name. Because they may see something like this, they may see something like this, or something like this. Those are all interstitial lung diseases. They're just different interstitial lung diseases with different patterns that a pathologist has to sit down and decide, does it mean this pattern, or this pattern, or this pattern? And there's actually about 8 of them. The patterns that you hear most commonly are probably these 2. UIP, usual interstitial pneumonia, NSIP, non-specific interstitial pneumonia, and then I put others because it'll start getting confusing with DIP, RVILD, PTND, and blah. These are the 2 most common things that we see. The reason why these were named this way was because the pathologists, when they were looking at all of these slides years ago and coming up with these names, the thing that they saw most commonly was what they ended up calling usual interstitial pneumonia. So it's not that it's the usual type of fibrosis, it was just the one that they saw most usually. Non-specific interstitial pneumonia, or NSIP, was named because it was a non-specific looking pattern. After they were looking at all the different patterns, there was one that was just sort of left over that they did see frequently, but it just didn't fit any of the other categories. So they named it with the unfortunate title of non-specific interstitial pneumonia. So when we say that, we're not saying it because you have something that's just non-specific and we don't really know what it is. No, that's actually a real diagnosis that a pathologist named years and years ago. And it's probably one of the more common ones that we see. And it's certainly one of the more common ILDs associated with other things, especially rheumatological or connective tissue disease causes. In fact, I've said this before, maybe some of you, it's not as true as it is now, but we used to say that if someone has NSIP and you haven't found the cause for it yet, you just haven't looked hard enough. We actually do know now that NSIP can happen without a cause, but that's actually really unusual. It's almost always caused by something else. And we may do all the digging and asking questions, et cetera, and may never find that cause, but that usually is what it's called. Usually is caused by something else. So let's sort of tie all this together. The reason why the pathologists were seeing the pattern that they ended up calling UIP so commonly is because IPF was probably the most common diagnosis they were seeing in getting biopsies on. So what we discovered is that for a diagnosis of IPF, the UIP pattern must be present. Those have to go together. If you don't have a pattern of usual interstitial pneumonia on a surgical lung biopsy that you may have had, you do not have IPF. So the pattern is not UIP, the diagnosis is not IPF. That's on a biopsy. We'll dig into that a little bit more in just a second. There has to be no cause for the UIP. So those are the two requirements if you have a lung biopsy. It has to have UIP, and UIP cannot be caused by something else. UIP can be caused by a lot of things. A lot of the things that I've named already, like the amiodarone. Amiodarone is notorious for causing UIP. Asbestos is notorious for causing UIP. That's not IPF. That's UIP caused by something else. So it has to be UIP without cause. And I've got a little picture that will explain that. But this helps out just to kind of really emphasize that point a lot. For IPF, you have to have UIP, but not all UIP is IPF. Okay? And as I said, the reason for that is because UIP can be caused by a lot of things. That's why we ask you all those questions, is because we're trying to determine if your pattern of disease caused by something else. The phrase we use in medicine is that it's a diagnosis of exclusion, meaning that we've reached the diagnosis and we've excluded everything else. It should make you a little uncomfortable if your doctor slapped you on with a diagnosis of IPF and spent about 5 minutes talking to you. That may not be the right thing to do, because we have to do everything we can to see if there's a cause for what you have. So that must be a biopsy, right? Well, not necessarily. And the reason I say not necessarily is because some really smart guys, mainly at the University of Michigan, sort of where this paper was published originally, it's been proven over and over again, that much like the pathologists were noticing that all their patients with IPF had the same pattern on lung biopsy, well, they sort of looked back and said, you know, we have all these patients that have had lung biopsy with UIP, but look at their CAT scans, they all look the same too. So let's sit down and look at these together, and is there something in common with the CAT scan that all the patients who had biopsy with UIP had? And in fact, they found it. There's actually 4 things. I won't get into what the 4 things are, but one of the main things that you have to see on the CAT scan is honeycombing, which is what we see there at the very bottom of the screen, those little holes, kind of like a honeycomb that you see from a beehive. So they reported that if the CT looked a certain way, having these 4 criteria, this is actually published everywhere, there's a greater than 90% chance that if we take a piece of the lung after that, it's going to show UIP. So if the odds are that high, the biopsy probably is not necessary. In fact, you know, with all the things that happen with a lung biopsy, you know, a hole cut in your chest, a tube stuck in, going to the OR, maybe anesthesia, we need to balance the risk and benefit of that. So if the CT scan is that good in predicting what the biopsy is going to show, if it looks like that, we can skip the biopsy. And in fact, the American Thoracic Society has said that you can make the diagnosis of IPF if you rule out other causes and the CAT scan looks like that. So that might be why some of you have not had a lung biopsy, but the doctor said you had IPF, is because you have what we call a definite appearing CT scan. That actually is the language we use. It's a definite UIP pattern on CT scan. If you don't have that pattern, if you've got something like this, or something like this, again, those are all interstitial lung diseases, then you might need a lung biopsy. Some of the reasons why you may not get them is sort of what I was saying before, is that it's not a simple in and out procedure that you do in the office and then go home. It's a big deal. I'm conservative with that. I will admit, I am certainly speaking for my partners, we're all rather conservative, because we understand that it's general anesthesia. And so if we're cutting open, you know, your chest and taking a piece of your lung, we want to make sure that we're not going to hurt you. That's the worst thing that we can do as physicians, is that we, you know, send you off for a procedure that makes you sicker than you may be now. And what if it doesn't help us? As I said, this is pattern recognition, so it's not like we're going to always get the answer when they go in and take a piece like that. If the pathologist looks and looks and looks and gets his partners to look at it, they just can't fit it into a pattern, what have we gained? So that's a very serious conversation that we always have with our patients, is that is this going to really answer questions for us? Is it going to help us treat you? Or is there a chance that we're going to make you feel worse afterwards and then not answer those questions? It should be that way with any medical decision we make, whether it's prescribing aspirin or of doing a surgery? What are the risks and what are the benefits? And with the lung biopsy, that is especially true. What are the risks and benefits of doing that? The phrase that I like to use is that there could be a very, very high price to pay just to give something a name, just to put a label on it. In my world, we get very comfortable with being uncomfortable. I tell my fellows who are young doctors who are trained pulmonologists that if you are going to go into this business and be really uneasy that you can't give a definitive diagnosis to every one of your patients, ILD is probably not for you. Because we all have had patients where we had a lung biopsy and things didn't go well. That's rare. Don't get me wrong. It's not a lung biopsy. Probably get lung biopsies and fluid is fine, and I do plenty of lung biopsies every year myself. Surgeons do them rather. But I take that decision very, very seriously. That may be why you haven't had a lung biopsy. It's because it's a big decision and you have to be sure it's going to actually help us. I hope this is at least answering some of this question. Why is it so hard for doctors to tell me what I have? Because this is difficult. It requires a lot of thinking, a lot of talking to you, seeing if it fits a pattern on CT scan, deciding if a biopsy is right, and then seeing if the biopsy fits the pattern. We may do all those things and still not know what it is. That happens. We actually have a category for that. It's called unclassifiable interstitial lung diseases. It actually is a real diagnosis. Because sometimes you do everything you can, and you just don't find a definitive name for this. And worse, they can all be the same. You know, just because you have IPF doesn't mean your symptoms are going to be different than the person who has asbestosis or has bird exposure ILD. They can have the same symptoms. CAT scans look the same, and the blood even biopsies look the same. It really comes down to really asking all those questions and seeing if something pops out that's a cause for this. And for UIP, this especially holds true because UIP, if I biopsy a patient with UIP from IPF or UIP from Parrot syndrome, the biopsy can look exactly the same. The CAT scan can look exactly the same. It has to do with knowing where it came from. That makes us smart. As I said, it really excites the importance of interview. So what can we do? We're all very excited about, in the era of the world of idiopathic pulmonary fibrosis especially. For so long, we did not have good treatment for this. Now that we do, that doesn't mean we forget all the other things that we used to do for patients with all types of interstitial lung diseases. Oxygen supplementation if needed, pulmonary rehabilitation. I can't emphasize the importance of that enough to condition your body to tolerate the shortness of breath better, make your vessels more efficient in taking care of the oxygen and carbon dioxide that it gets. And then lung transplantation when it's needed, when it's indicated. I'm not a transplant pulmonologist, as many of you know, but I know those guys very well. Many of my patients have had lung transplants. I can speak semi-intelligently about transplant if you guys have some questions about transplant after we're done here. But what about drug options? Well, why am I not giving Ofev or Esbriet? These are the two FDA-approved medications for IPF. That's the key. They're approved for IPF. That's why it's so important that we do everything we can to see if you actually have IPF risk. Now we do have therapy for it. The FDA approved these drugs for IPF, not for other interstitial lung diseases. That's why this accurate diagnosis is so important. If you have some other ILD, there are other things that we use, and that's the combination of things you guys may have seen before, things like steroids, mycophenolate, azathioprine. These are immune system suppressing medications that may help this scarring of inflammation in your chest. Maybe, maybe not. Again, those are decisions we make together. I can tell you that we are very interested in seeing how these antibiotic drugs work for other types of ILD. And I know that our colleagues in industry are very interested in this too. So stay tuned. We may be seeing some of these medications used for other types of ILD very, very soon. So in conclusion, interstitial lung disease refers to these large group of conditions that may have similar symptoms, similar CT scans, similar biopsy appearances. Idiopathic pulmonary fibrosis, or IPF, is but one discrete type of ILD. It's under the ILD umbrella. A diagnosis of IPF can be made without a lung biopsy if the CT scan was a certain way and we identified no underlying cause for the ILD. Other ILDs often require diagnosis, a biopsy for definitive diagnosis. The CTs fit patterns usually too. The CT scans that I showed you guys a couple of times are actually very, very textbook examples of NSIP and protogenic organized pneumonia. One of our partners here, you guys know Fitzgerald, he's a master at this. He is just so good at looking at CT scans and knowing what they are. That's why we lean on him a lot when looking at CT scans. Because a lot of times a CT scan fits the pattern of these other things also. So we may make that a presumptive diagnosis of biopsy because the CT scan looks so much like what the biopsy will show. An accurate diagnosis is so important because the therapies differ for different ILDs. Thank you very much for your attention. I'm very happy to answer any questions.
If you have a question, could you raise your hand and call on you? I know you have a question.
I do.
Okay. My question is.
Oh, I do.
You do? I know you do.
What websites do you think can give you the most accurate information?
I think Pulmonary Fibrosis Foundation is probably the place to go. There's that website, and there's also the Coalition for Pulmonary Fibrosis. I think those are probably the places to get comprehensive information, not just about support groups, for example, but they also tend to keep track of clinical trials that are ongoing. They can direct you to the clinical trial website where these trials may be ongoing. I think we put up today pretty well too. So I think Pulmonary Fibrosis Foundation is like pff.org, Lucy Dress.
PulmonaryFibrosis.org.
.org, there we go. Those are probably the two places that I would go to first.
The coalition was actually assimilated within the Pulmonary Fibrosis Foundation.
Great.
So it's one site that has all the information from both of those organizations.
I think that's the best place to go. It's objective. Be careful of Google. You'll end up reading blogs and stuff like that. And I find that the problem with other types of websites is that they get a little subjective. And they may be talking about things that don't apply to you. Talking about one disease that they didn't diagnose, that they're talking about, but I don't did this for my disease. That may not apply to everybody. So that's why I just have a healthy skepticism of what you read on the internet. But the Pulmonary Fibrosis Foundation, I think, is pretty objective, and I think that's a good place to see. Yes, ma'am.
I've seen, as far as medications that cause IPF, I've only seen, I think 3 at the most. I'm curious, I would like to look back, where you said there was like a whole bunch of other ones. Where can I find the complete list of medications that are known to affect ILD? And
There's a medical website that's free. You can get on it. It's a little techie. That's the reason I say it's a medical website called pneumatox.com. I believe that.
Can you spell it?
It's PNEUMOTOX. The list of drugs, and what that is, that's not a list of drugs that cause ILD, it's a list of drugs that cause any type of pulmonary issues. Right. And what it actually shows, it links you to any report of this. So we also have to be a little cautious with that because if you look up, I don't know, aspirin, let's say, there may be one report 20 years ago that somebody published of somebody who got pneumonia that took aspirin, and so they'll maybe list that there. It doesn't mean that you're going to get pneumonia if you take aspirin. I don't know that aspirin causes pneumonia, just using it as a bad example. That they weight the evidence of that. So if it doesn't, so you can't look, you can actually search for ILD and it'll list all the drugs that have reports of that, but some are stronger than others. So just because you took one medicine one time doesn't mean that caused your ILD. But some things are much more likely to do it. And like I said, there are certain chemo drugs that are very, very well known to cause that. But that might be a good place to go look for that.
Well, I found that, and if, I don't know how other people, I have a 25-year medical background. Google Scholar, and you can get on and read papers.
So Google Scholar is like PubMed. Google Scholar is like a lit search. What Pneumotox will do is sort of take the Google Scholar and make it a little bit easier, because with Google Scholar, what it'll do is it'll link you to case reports or whatever reports. Pneumotox will do the same thing, but it's a little more honed in on one things. And Google Scholar, I think, is a little medically heavy. It's like me doing a lit search in the hospital on a patient, and I think that for someone who has little to no medical background, Google Scholar, I think, is a little tough.
Is it pneumotox.org or
I think it's .com. Tion, do you know? Again, I haven't looked. I think if you just type in pneumotox, like in a web search engine, it will pop up probably. I don't remember exactly what it is. There's an app actually too. There's a pneumotox app.
I have another question.
Yes, ma'am.
What do they mean? I've had angiogram with contrast, and they talk about ground glass opacity. What does that mean? I've looked everywhere and cannot find a definition.
So, does anybody know what ground glass is? Medical construction. You like that? No. You want? No? So, it's .org thing, so it's pneumotox.org. So, ground glass is that stuff like you see in buildings that's like frosted glass. So it's glass that you can kind of look through, but it's not quite clear, so you can kind of see what's behind it, but not really. It's something that people decorate their homes with and stuff. Someone came up with that term to describe like this up in the left upper corner there. See where it's a little hazier? So I can kind of see the lung behind it, but not really. That's ground glass. That's called a ground glass opacity or ground glass infiltrate. Doesn't mean you have glass in your lungs. Much like this honeycombing description, you don't have honeycombing lungs. Someone decided, hey, that looks like honeycomb, so we're going to start calling it. Someone did the same thing with ground glass, and that is now into our medical lexicon as a descriptor. One of those 4 criteria for UIP is you have to have basically no ground glass. A UIP pattern has little to no ground glass on it. So if you have more, I think it's like 5% of the entire CT scan that has more ground glass than that opacity, that actually rules out a UIP pattern. So that's one of the things that puts UIP different from some of the other things. This is organized pneumonia. This is usually very, very steroid responsive. And ground glass often implies that it's acute inflammation that can be steroid responsive. That answers your question? Ground glass is, so ground glass is I think the doctor's offices, it's like it's decorative, but it also gives some privacy to it in essence when you get that.
I was wrong. It is .com. There's also a pneumotox.org.
Okay, so pneumotox.com. There's a pneumotox.org, really? I didn't know that. Yes, ma'am.
In one of the slides up there, you showed the fingers with arthritis.
Yes.
I didn't really understand how does arthritis apply to this.
So there are many.
Yeah, I have my finger looks just like that.
There are many chronic systemic diseases that are known to be associated with interstitial lung disease. Rheumatoid arthritis is one of those. Rheumatoid arthritis causes many types of lung things, not just ILD. It can cause lung nodules, it can cause fluid around the lung. So if you have a diagnosis of rheumatoid arthritis and an interstitial lung disease, they're almost certainly connected. It's not that the RA causes it, it's just they're associated with each other. If anybody has visited with a rheumatologist before, they are very black and white doctors, meaning that you've got to have all of the criteria for a diagnosis for them to give you that diagnosis. Rheumatoid arthritis has like 4 or 5 essential criteria to make that diagnosis, and so it's more than just the hands. You have to have some other things that go along with that. I just use that as an example. That's somebody who has active arthritis doesn't have that big red finger like that. So it's actually not the part that's the bad part is the red finger. It's not the other finger. It's that big red, swollen, angry joint. And some people have these. The ILD comes first. We see that a lot, where they'll have some things kind of suggestive of a rheumatological disease and ILD, and then only later over the years does the full rheumatological disease evolve. That happens sometimes. We actually have a name for that too, but I don't think that's on separate conversation.
So are you treating the rheumatoid arthritis or are you treating the ILD?
So medicines are different sometimes. Like the things like Humira, Enbrel, Remicade, those kinds of things that people get from rheumatoid arthritis, they do not work with the ILD. So often you have to treat them separately. But also with the things like CellCept, mycophenolate, azathioprine can help, but it just kind of depends what the major factor is. In a good dialogue with your rheumatologist, we have several rheumatologists that we work very closely with, and if they are tempted to take medications away because someone's arthritis is under great control, I want them to talk to that person because the medicine may also be helping the lung disease. And I'm like, don't take those things away because the joints are great, I can still use them for a while, and vice versa. It may be that they're more popular more with their joints and not the lung. Everyone's different. But sometimes medicines don't overlap. Yes, sir.
Are you familiar with the study that they're doing at the University of Colorado in Denver called the SARA study? It's relating to rheumatoid arthritis and antibodies in the blood that end up showing markers.
I don't know the specifics of that. No, I know that there are some clinical trials of some of these medications for RA-induced ILD, but I don't know the specifics of that, sir.
Mr. Bill, are you going to send us a copy of these slides?
Yeah, I'm talking about a second. I have a question. One of your areas of responsibility has to do with clinical trials, and I think many of the patients here are interested, well, can I participate, how should I, could I, and why should I? Because you talked about clinical trials.
Yes, just because we have some improved therapies for IPF now doesn't mean that the research has stopped. In fact, it's become more robust than it was before. And we have, not just we, other medical centers are continuing to do clinical trials of IPF and other ILDs for that matter because there may be more that we can do. And so the advantage would be in joining the clinical trial is that you may have access to some treatment that is not available yet. It may be able to augment what you're taking already. All clinical trials of IPF drugs, there was one that was still lagging behind, but that's now also a go, will allow you to stay on your therapy in the trial. So you don't, it's not like you have to be off your straight off your off. You just have to go and stay with those for a few months. And that's allowed. So the advantage is maybe something that will help you even more that you wouldn't have access to otherwise. I find that a lot of patients with these diseases are very interested. That's why you're here. You're interested not only in learning about your own disease, but in meeting other people. So this helps advance the science of this, and not only may help you, but may help other people in the future with this by helping us gather clinical information about their disease and what the response to these treatments are. We approach almost everybody in our clinic at some point, if they have IPF, most of our trials are about IPF, about joining either a clinical trial with medications or a registry trial. Registries are very, very important because that allows us to learn more about the commonalities of everyone and report associations that may not be known before, like associations between weight and IPF, things like that, as we gather all the information. we don't like to overwhelm everyone. We have 3 registries right now, and two clinical trials right now of IPF enrolling, and we have a 3rd with ILD from scleroderma that's enrolling right now. So these are all things that we can offer on top of the normal things. So it's just another level of care that may be available to you by joining a clinical trial, advancing science, helping others, but also perhaps helping yourself by getting something you wouldn't have otherwise. And I think a lot of you may have been participants in the trials that led to the approval of Esbriet and Mofev. We thank you for that. Really, you help the world by enrolling in those trials and giving us that information.
Dr. Kershaw, thank you. Thank you. Working behind the scenes while all this is taking place. That's John Rose. John is conducting a virtual meeting as we're having our physical meeting. And after we have a short break, I'll let John talk a little bit about that. Then Steve Winnell is doing videos of our meeting that we share online. So what you have seen here today will be available to you online on the PM4 site. And we'll talk more about that. What I'd like to now is take about 5 minutes. Restrooms are out to the left or right when you walk out the door. There's snacks and water and treats in the back. Let's take about 5 minutes, but when you come back, I'd like you to find a way to sit so you're facing somebody else. Maybe moving around the corner to face each other, because we're going to do kind of a fun part of the meeting, and that's talk about ourselves. So let's take 5 minutes. It's 10 after, so 15 after we'll reconvene.
If you have any questions, I've unmuted you from my end. Everybody's still there. So if you want to ask a question, go ahead and unmute. Excuse me. Or use the chat feature. I'll give us a couple minutes in the meeting.
How do we do, John?
We had 6 people.
Good. Good test.
Plus a couple on the phone, but 6 on the via the web app.
Did any have questions or just?
Not yet. No. You're still online.
We are.
Yeah.
Okay. Well, good. Let me say hi. That's it.
There you go.
I think the whole virtual concept is exciting, and I have to thank you and Nancy and Steve for putting it all together. It's a great job, and it's going to really help a lot of people. Particularly, I'm looking at some of the names. We have people that I know are not necessarily accessible to Dallas, and we've had people at our last meeting from Oklahoma, Odessa, Tyler, and it's hard to come to Dallas for a meeting.
Yeah.
But it's a lot easier to sit in front of your computer and pop a button and here you go.
This is what everybody's seeing. They're seeing the splash screen in our
Oh, that's outstanding. Did a great job. Thank you.
All right. Okay, folks. Well, like I said, thanks for joining us. And I'm going to post this online on the Kev Warrior website after we get home. Yeah, right. Like I said, if you have any, there you are. Hi, Debbie. If you have any comments or ways we can make it better next time, my email address is jrsto@yahoo.com, or you can just email me. Either way, this is best as possible. All right, thanks for joining us. We'll see you next time.